Hello, I'm Val. I've worked with individuals, couples, families and organisations. When I was a police officer, I was trained in critical incident debriefing. I've worked with the Ministry of Defence, soldiers with trauma. I work with one of the UK's ambulance services. I've worked in a prison, a rape and sexual abuse centre and with youth offending teams. I've worked in lots of different agency settings and I'm currently working in private practice where I see people with trauma. We're going to have a look at a few bullet points in relation to trauma that may be particularly of interest to you listening to this at the time of the pandemic. So trauma could be a presenting issue or defined as a human experience. It can present as a single or a multiple incident. And there are various aspects to it that we're going to look through quickly now. Risk assessment, NICE guidelines, existing models, some approaches to trauma and some COVID-19 and trauma specific resources. If you're a practicing therapist listening to this, you'll obviously have a supervisor, ethics and a particular way of working. But in all cases, it's perfectly acceptable to offer your clients some psychoeducation, which helps to normalise the experience that they are going through. So watch and wait is one of the NHS's prescribed interventions for trauma. In other words, do nothing. Time may heal. One of the aspects of trauma is what we call vicarious trauma. So if you've experienced trauma directly, that's called primary trauma. Secondary trauma is where you witness the aftermath. And then vicarious trauma is where you hear about it, which is where a lot of mental health professionals sit. There's a fourth term, which is transgenerational, where you can be a descendant of someone who has experienced trauma. Whatever your way of working, there should be some element of risk assessment around PTSD. A medical diagnosis of post-traumatic stress disorder requires certain criteria to be in place over a given period of time. There are various different ways of looking at it, but I'm going to talk briefly about the Diagnostic and Statistical Manual of Mental Disorder, often known as DSM-5. And there are currently 8 criteria required from DSM for a diagnosis. So they are very briefly directly witnessing or learning of or extreme or repeated exposure to a traumatic event, then re-experiencing repeatedly thoughts, images, flashbacks about that event. Thirdly, avoidance of thoughts, feelings, people and places related to the trauma. Then there is alteration of thought or mood. In other words, you feel alienated, you have loss of interest in things. Then what's called alteration in arousal and reactivity, which means people can be irritable, have disturbed sleep. And then the above 5 need to be persistent for a month or more. Significant functional impairment, in other words, things like not being able to work, are another criteria. And then finally, not having trauma related to substance abuse, other medication or illness. So I've quickly outlined them for you there, and whether you're familiar or not with DSM-5, you can easily research that if you want to know more about it. So, NICE guidelines. There is cognitive behaviour therapy, trauma focused. There's EMDR, eye movement desensitization, reprocessing, and then there's medication. Or maybe you don't want to work with NICE guidelines. Maybe there are other ways of working. So what's known as medical models, where a psychiatrist will prescribe medication or a clinical psychologist will work with a formulation, or non-medical, non-pathologizing models that counsellors and psychotherapists work with, all are different routes to helping people feel better. Even in the field of counselling and psychotherapy, there are different approaches. You may have trained in humanistic, psychodynamic, transactional analysis, systemic, integrative. But again, we are all trying to help people feel better. Organisations, though, who purchase mental health intervention services are often only interested in commissioning them if they are evidence-based, which is why it's perhaps useful to look at some of the NICE guidelines. So there's trauma-focused CBT. There's EMDR with a couple of links if you're interested in knowing more about it. And then I've listed the NICE guidelines themselves, here only for adults, not children. If you're interested in looking at what the NHS has to say about PTSD, then I've given you the link here. And then the third and final intervention for under NICE guidelines is medication, the use of medication. And the types of medication are listed here. And as it also suggests here, there are 3 or 4 circumstances in which medication will only be used. And it's usually SSRI antidepressants and anti-anxiety medication. In terms of some existing models, we've all heard of fight, flight or freeze. Peter Levine wrote a book called Waking the Tiger. An interesting angle, looked at how animals respond when they're traumatized. Something known as the rewind technique. If you want to have a look at the Poppy Company, it tells you more about how they use the rewind technique. And then Stephen Porges' polyvagal theory. There is growing neurobiological research in terms of the role of the hippocampus and the amygdala in the brain, and trauma's effect on all the body systems, the nervous system, the cardiovascular system, the gastrointestinal system and the hormonal system. Another model you may have heard of is Pat Ogden's sensory motor psychotherapy. And she is accredited with working with the window of tolerance, so somewhere between hyper-arousal and hypo-arousal we can work to help people deal with their traumas. You may have heard of TRIM. TRIM is a peer support system used in organisations, and on this slide you'll see a link to Professor Neil Greenberg, who is working at King's College London, and you can see him here actually conducting a TRIM interview. Babette Rothschild wrote a book called The Body Remembers, and in her subsequent case book she talks about trauma in relation to different psychotherapy models, be it TA, Gestalt, psychodynamic, NLP, CBT. And she's a proponent of somatic memory. So when you're working with someone who is traumatized, she stresses the importance of knowing how to ground somebody in the moment if you see that they are re-traumatizing in any way as a result of talking with you about the effects of the trauma or even the trauma itself. Judith Lewis Herman did some seminal work, and her book Trauma and Recovery is linked here. Again, she stresses the importance of working with the effects of trauma, not the trauma itself. Most counsellors and psychotherapists have heard of attachment theory, in particular Bowlby's attachment. His research was done with children and indicate that we all develop one of 4 main attachment styles, be it secure, avoidant, resistant or disorganised, as shown in this diagram. And the attachment style we develop stays with us into adulthood. There's a lot of books on the subject if you want to do more reading and haven't done so already. I'd also like to mention briefly my own research with clients over the years suggests that people who present with trauma or any kind of trauma symptom have had in their past a narrative that involves difficult or insecure attachment as children. Mentioning very briefly the role of grief in trauma, William Worden's book on complicated grief is worth looking at. A final one to mention, although there are many approaches to trauma, is van der Kolk's work He wrote the famous paper, The Body Keeps the Score, which highlights the role of psychobiology in trauma. Mental health right now, quite rightly, is under the microscope. But I want to mention that 1 in 5 people who are unfortunate enough to be on a ventilator, if they are in intensive care units, do leave with some kind of post-traumatic stress, be it the drugs they've had to have or the environment that they're in. And this is pre-COVID. Similarly, if you're working with a professional who's on the medical front line, it might be that their trauma comes from the fact for the first time they're dealing with a disease that we don't know about, and therefore its effects on the body and how we're treating the symptoms are unusual, even to the most experienced professional. So there are 2 resource listings here, and many more listed here, which hopefully you'll find useful. The final thing I'd like to say is that the ethics of all mental health professionals includes the importance of looking after yourself as much as you look after other people. Thanks for listening.